My name is Dr. Leslie Sim. I'm in the Department of Psychiatry and Psychology at the Mayo Clinic. The title of the article is Identification and Treatment of Eating Disorders in the Primary Care Setting, and it's in the August issue of the Mayo Clinic Proceedings. Eating disorders are very serious conditions that involve a number of medical complications and serious psychological problems. With eating disorders, the primary concern is that hospitalizations are on the rise and healthcare costs are quite high. So it's very important for primary care providers to be able to identify these problems early and guide these families and patients to appropriate treatments. Interestingly, over half of patients who are first diagnosed are seen and diagnosed in the primary care setting, and that really suggests that primary care providers are in an instrumental role to be able to identify these patients and guide them to appropriate treatments. So anorexia is characterized by a refusal to maintain an appropriate body weight for one's age and one's height. The hallmark of anorexia is an intense fear of gaining weight. Many individuals with anorexia also have a disturbance in the manner in which they perceive their bodies. So they typically see themselves as much larger than they actually are. But a number of individuals will recognize that they are too thin, but the disturbance really is reflected in the way that they see the low weight. So essentially they don't recognize the seriousness of the low weight. To be diagnosed with anorexia, you have to have some physical sequelae of the low weight and poor nutritional status. And essentially you have to have the loss of 3 consecutive menstrual periods if you are a postmenarchal female to receive the diagnosis of anorexia. There are actually 2 types of anorexia. I think most people are familiar with the restricting type, which represents about 50% of patients. So these individuals eat very little or they don't eat enough to maintain appropriate body weight. But actually 50% of patients with anorexia would be characterized as having the binge purge subtype. So these are individuals who would engage in regular bouts of binge eating and or purging behaviors. In terms of recognizing anorexia, as I mentioned earlier, many individuals are in denial about the seriousness of the problem, and they're very threatened by having to gain weight. So they may not be very open in terms of recounting symptoms. So in many cases it can be helpful to discuss the symptoms with a family member or parent who might be able to give you a better picture of the patient's actual behavior. In terms of managing some of the medical complications, electrolyte abnormalities are fairly common in patients with anorexia, particularly in patients who vomit. We do try to keep track of patients' serum potassium, and when it drops low, we do need to supplement that, and we will hospitalize when the level goes below 2.8, and we'll supplement at 3.2. Individuals with anorexia who are undergoing the refeeding process are also prone to hypophosphatemia, or a precipitous drop in their phosphorus, and so they need regular monitoring of their serum phosphorus levels, and we will supplement if necessary or simply reduce calories. So these patients are also prone to cardiac abnormalities, so we will monitor with electrocardiogram for any of these. In terms of appropriate treatment for the anorexia, patients are commonly prescribed selective serotonin reuptake inhibitors, but the evidence base for this is pretty poor, and there's not a good evidence that those medicines will specifically assist with improving symptoms of anorexia, improve low weight, or prevent relapse. Those medicines can be helpful, however, to manage some of the comorbid psychiatric symptoms such as anxiety or depression. The best psychosocial treatment we have is actually for younger patients with a shorter history of the illness, and it's actually a family-based approach which essentially puts parents in charge of the refeeding process and helps these patients to restore their weight. adult patients can be offered as standard psychological treatment called cognitive behavior therapy. Bulimia is actually characterized by recurrent bouts of binge eating. A binge episode is distinct from an overeating episode in that it involves eating a large amount of food, but also having a loss of control over one's eating. There are two types. The purging subtype is where patients use more invasive measures to prevent weight gain, such as vomiting or laxative abuse. The non-purging subtype will be diagnosed when the person does things like excessive exercise or fasting to prevent the weight gain. The physical exam can be very helpful to identify bulimia nervosa, and there are many different physical signs that the primary care physician can look for during exam. In particular, we're going to look for lacerations to the mouth and throat due to self-induced vomiting. Enlarged parotid or salivary glands are also quite common. Erosion of the enamel or dental caries are fairly common and are often recognized by dentists. Fluctuations in weight or Russell signs, which is a callus on the dorsum of the hand. So physical exam can be really important in the diagnosis, but also there are some screening tools such as the SCOFF, which is a 5-item questionnaire that can briefly assess for eating problems and eating disorders, and the Eating Disorder Diagnostic Scale, which is a fairly short measure and can diagnose anorexia, bulimia nervosa, or binge eating disorder. In terms of management, treatment needs to be provided for the consequent symptoms of vomiting and binge eating, and really including chronic gastric reflux, delayed gastric emptying, constipation, and esophagitis, peptic ulcers, and the like. There are two very good and effective psychosocial and psychopharmacological interventions. In terms of psychopharmacology, high-dose fluoxetine has been shown to be pretty effective. Psychosocial treatments, the best and most effective treatment is cognitive behavior therapy. And this has been shown to significantly reduce symptoms of binge eating and vomiting, as well as lead to remission of the disorder. I hope that primary care providers can take away the fact that eating disorders are very serious psychological illnesses associated with a number of serious medical consequences and psychological symptoms, along with substantial reductions in the quality of one's life. So the primary takeaway message from our article is essentially that patients will benefit from a coordinated multidisciplinary approach to treatment that would involve sophisticated psychological therapies, pharmacological treatment, and importantly, medical management and monitoring.
We hope you benefited from this presentation based on the content of Mayo Clinic proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.